This looks like the breast cancer problem. Whirlpool-like. There is no cookie-cutter solution here. Case number 3, 52. Self-detected palpable tumor in the upper outer quadrant. Would you be kind enough to come with me? We do perception. Which breast? Right or left? Easy to read. CC projection. No, this is not the way we are looking at a mammogram. AI, hide yourself. This is the way. I beat AI. This method beats AI. Tell the AI people. They are going to say, yeah, right, Laszlo again. If you haven't picked it up so far, you do it now. There is a non-specific asymmetric density, ill-defined and convex contour in the place where 61% of the cancers grow. Why didn't you pick it up? Nothing behind the nipple, nothing in the lower half of the breast. But in the lateral half. Right there, you think it's a lymph node. Oh, sharply outlined. You're wrong. Don't ever try to be clever when looking at screening mammograms, unless it's an obvious calcified fibroadenoma. This was missed at this time point, and that's the reason why she died. Because in 13 months, this happened. Grow up. AI, you should have reacted earlier. No calcifications, ill-defined, microlobulated. Dyes in the middle. I would expect the desert. When you are doing ultrasound, look for it. You got very good help from ultrasound. And this can only be one of the two. Either it's an additional, let's say DAB, or just fibrostrands. Surgery. Now there are two. This one looks like an intramammary lymph node, or nodes, a whole little family here. I already see the desert. I am going to see the desert much better like this. And here is the corona. If I ask you to vote, nobody would say this is a AAB. This is 16 millimeter, 16 by 15. Let's go. Still pictures are great, especially if I write on them, but I hope that you don't mind that I introduced the videos, although it takes a lot of work, a lot of time, but I hope you enjoy it, because this way we can talk more about, and then I can draw on it. So now we have a very good grip on the desert and the surrounding, and all these mitosis and huge nucleoli, tightly packed, very poorly differentiated carcinoma. So this is not a good, this is not a bad, this is very bad. We call it ugly. This one would be responsible for the rim enhancement I'm drawing here, the viable cancer cells and the empty middle. I would also love to know whether there are neoacini or neoducts. Let's say neoacini because it's still so small. For that, we have to go in deeper and drive around. However, you should think about that this, what I'm showing you, measures only 4 micron. In 16 millimeter, there are 16,000 microns. Yes, there are some duct-like structures here and there, and I'm going to show you more. Here it is. The mother of all these bad boys. You see the lymphocytic infiltration. This is step 2, but what dominates the picture is step 3. Then calcify. Look inside. What a mess. Apoptosis, viable cancer cells, disconnected cancer cells, detached. And here are again the longitudinal structures, duct-like, we call it DAB. Neoduct genesis, neoacinogenesis. Nearly synonyms, one of them is small, the other one is long. When the cytokeratin 5-6, cytokeratin 14, and the epithelial growth factor receptor are positive, then it's called basal-like. I already mentioned to you, don't ever make a fool about yourself and asking the pathologist, where are the basal cells? They are going to laugh at you. There is no such thing. None. There is the basement membrane, myoepithelial cell layer, and there are the luminal cells. Basal-like, it's a very strange expression. It is the combination of this, and the epithelial growth factor. If most of these or all of these are positive, that's basal-like. I didn't like this one, 85%. Now we can understand why it grew fast. Not enough with basal-like, it's triple negative. Does this scare you? Well, we found the previous case was not triple negative and it was not basal-like, and the patient died. There are only isolated cancer cells, but she's very much on downhill. 18 months after diagnosis and treatment, mind you, modern treatment, chest wall metastasis. The desert again. Dedifferentiated DAB, dear colleagues, this is step number 3. They are so loose as they ever can be. And she is gliding on this curve. Mother Nature unfortunately put her there. 3 years and 9 months after diagnosis initiation, the patient died from the differentiated DAB. These lectures put emphasis on improving your knowledge about histopathology. Of course, we are using the perception, the multimodality approach to arrive at diagnosis, but I'd like you to be proficient in histology as well. I take one more case, 56. Easy. Stellate lesion, smaller than 14 millimeter. Whoops. Why do we magnify? Because we want to see satellites we couldn't see, but we saw something here which hopefully is going to be seen much better here. Is this AAB? Is this mini BCMO the good and bad? Or when I see short castings, not only within, but preferably outside, then I drop these. It has to be the ugly. Let's go for it. You have to vote for yourself, and you would do this very simple thing. What is the structure here? That must be a duct. Or an acinus. In that case, battle is over. Very ugly cancer cells. And also, I see this. Good pathologists describe this in their report. When we are photographing the slice specimen and also magnify it, then we see these malignant type calcifications. No doubt about it that this part is the dedifferentiated, and this is the mother. We are going to try to chase that too. What's the size? Think about the mammogram. I take the largest distance and it's maximum 10 millimeter. And from there to there could be 8 or 9. 9. So let's try to travel around. Already at this time point, I'd like to call your attention that there is an intratumor heterogeneity. The structure here is different from here, is different from there. Oh, here is our mother, not only one, but there is a neighbor as well, acinus. That one I'm drawing in the left side, 9 o'clock position. Here is another one. You just have to look for it, or the pathologist, or they have to slice and slice and slice because it's always there. This is the DAB, step 2. And this is step 3. Look at the difference. There are no boundaries here. We are loose. We are just doing whatever we want. For example, we are going to grab that little vessel right there, full of red blood cells. When we have broken into that, then we are moving out to the interstitial space. Here are the fat cells tightly packed to each other, and among them there is the interstitial space. And I'm trying to mark the cancer cells in that. The horse is out of the barn. Really. You see the difference on the right side? It's more of a so-called invasive micropapillary carcinoma, as if there were these oval openings and smack in the middle, the cancer cells. Very ugly. At 3 o'clock and 9 o'clock, different types of cells. This is what I wanted to show you when you see this pattern, so-called invasive micropapillary. If I encircle this area here on the left and a little bit on the right, you see what I'm saying about intratumor heterogeneity. During the preparation, a central portion of the desert fell out. There is so much information on this. More of the DABs, still pictures. Step 2, step 3. We have our lovely colleague from Greece, actually from Crete, Dr. Tsagaraki, who was kind enough to give us the first drawing, you remember? Those beautiful pictures, the luminal cells in AAB. This time, I think you really got the essence of the happening here. Although this is the mother and this is the child, unfortunately, the pathologists are writing that within the invasive tumor, there is in situ. That's just the other way around. This is the mother and this is the child. It's important that the pathologist says it's outside. Just like this little stellate lesion I showed you, the short castings were outside. Because when we have a stellate lesion which originated from the TDLU and it's in a situ stage, it might have undergone necrosis. And here are the cancer cells. The so-called in situ is inside the tumor. Here, it's outside most of the time. Here is the answer, unifocal, 11/8. This is the important thing. De-differentiated neoacinogenesis. That's the devil. This is unfortunately called DCIS, and it's wrong. So what do you think about crystal ball? I just showed a similar one, and she died. This case, she didn't. 17 years passed by, and even more. Patient is okay. Let me believe that Mother Nature placed her here, and in other cases, Mother Nature places her here. We have to study this more. That's the goal of my Saturday courses. Not only showing you cases, dear colleagues, but to ignite thoughts and ideas in your mind.